Um, all right, Colleen, you can hear me and see the screen?
Yep, we're all good.
Okay, great. All right, so we will get going. All right, well, thank you for attending today's Food for Thought. We're going to talk about some new ways to assess daily functioning assisted by technology, some old technology and some newer technology. So let's get going. Here are my disclosures. Aside from doing this type of research about daily functioning that's funded by the NIH, I also run clinical trials at Brigham and work with different companies consulting for clinical trials as well. So let's talk about activities of daily living, and here are some definitions for you. So basic activities of daily living consist of eating, dressing, toileting, grooming, and bathing. And these are intact until pretty long in the course of Alzheimer's disease. You really need to be very impaired to start having difficulties with these type of daily functioning. Instrumental activities of daily living are more complex. They consist of managing the finances, healthcare matters using public transportation or driving, shopping for clothes, preparing meals, cleaning, doing the laundry. So a higher level type of daily activities. And IADL is abbreviated, instrumental activities of daily living, are impaired when you have mild dementia, as well as to a lesser extent when you have mild cognitive impairment, which is an in-between stage between normal aging and mild dementia. So where do IADL fit in the early stages of Alzheimer's disease? There's been a lot of disagreement actually in the field about whether or not mild impairment and IADLs should be allowed in the diagnosis of mild cognitive impairment, which often leads to an arbitrary distinction between later stages of mild cognitive impairment and mild dementia. Some researchers and clinicians think that you have to have impairment in daily functioning to have dementia, and some think that you cannot have impairment in daily functioning when you have mild cognitive impairment. But of course, these are arbitrary decisions. And so one potential explanation is that we may have a lack of sensitive, ecologically valid tests for early changes in daily functioning that can be detected at the stage of mild cognitive impairment, or even before that, in preclinical Alzheimer's disease. As you know, a lot of the work we do at MGH focuses on people at risk for Alzheimer's disease who don't have symptoms or have really minimal symptoms, led by Risa Sperling and Keith Johnson. And so my thought here is that we may be able to even detect some very early changes in daily functioning at that stage if we ask the right questions or ask them the right way. So early changes in daily functioning. So there are a lot of subjective scales or questionnaires that are out there that we use to assess daily functioning, and there are not as many objective or performance-based tests, and we'll talk about the distinction in a bit. Most of them have been validated for the stage of dementia and fewer for mild cognitive impairment, and really none for people who are cognitively normal who are at risk for Alzheimer's disease. However, like other deficits in Alzheimer's disease, you could potentially have subtle difficulties in IADLs before the stage of MCI, again, if you have an ability to test it properly. So here are some categories of IADL tests that are commonly used. So subjective scales or questionnaires are the most widely used. Usually they're asked of a study partner or caregiver if it's in a clinical setting. And some have also a participant or patient report directly. And these will be usually a variety of questions about the different type of IADLs that I mentioned before, managing the finances, driving, taking your medications, preparing meals, things of that sort. And basically asking, often, as I said, a study partner or caregiver, can the person do these activities as well as before with some difficulty with help, or are they completely dependent? Performance-based assessments are considered to be more objective. They're not as widely used. Usually individuals are asked to simulate everyday tasks or are observed performing tasks directly. So depending on which type of assessment it is. And these are considered potentially more ecologically valid. And there's some hybrid, excuse me, hybrid assessments that combine daily functioning and cognitive concerns. And these are being used more widely now. Usually, both the study partner and participant report on the difficulties in daily functioning and cognition. And these give you a more global functioning type of idea, which of course is relevant in people who are at risk for dementia because you have cognitive deficits as well as daily functioning deficits, and some of these also include neuropsychiatric symptoms or behavior changes. This busy table just gives you a bit of an idea of the ability to differentiate between CN stands for cognitively normal, older adults, MCI, mild cognitive impairment, and in this case, AD is AD dementia. So trying to distinguish between these different diagnostic categories. So the FAQ is a very commonly used subjective questionnaire. And you can see that it distinguishes well between these three categories. However, if you look at the cognitively normal group, their performance is essentially 0, and this scale is a 0 to 30 item scale. And so basically, they're all performing completely normally on this test. And so you're not really seeing changes at that stage. You're just seeing that it's different from people who have mild cognitive impairment. If you look at another questionnaire, this one differentiated the ADCS-ADL, differentiated well between normals and dementia, or between MCI and dementia, but not really between normal and MCI. So even weaker for that perspective. And then the CDR is one of these hybrid tests, which performs well for distinguishing between categories. But again, for cognitively normal individuals, is as 0. Basically, you have a completely normal score on it, and so you don't really see changes there. The everyday cognition, or ECOG, is a subjective questionnaire that asks about both cognitive function as well as daily functioning, and asks both participant and study partner. And this one, you can see, distinguishes well between the three categories, but also has a little bit of a signal in the normals. They're not, 1 is the lowest score, and they have 1.4. So it's not completely normal. You can see some daily functioning changes there. Oh, I apologize for that. And then the last three assessments are performance-based or objective. This TFLS, which was developed in Texas, is really only able to distinguish between normal and AD dementia. It's a pretty old test, and people who are normal perform well on it. The next two tests do actually have a signal in normal individuals. The UPSA, developed in San Diego, you can see a little bit of change, in fact, in the normals, and also the financial capacity instrument, and especially actually with a new version of the financial capacity instrument that focuses on the more challenging tests, you can see some changes in normal individuals. And so there's some movement in the direction of picking up changes in normal individuals who are older, who are at risk for decline. So what can we do to develop tests for IDLs that are more sensitive for the early stages of Alzheimer's disease? So, I'm not saying that these assessments are better than cognitive assessments for detecting manifestations of Alzheimer's disease, but they're likely a better proxy of the real life function that may be more clinically relevant. For example, if we do a memory test with a long list of words that we're asking you to remember, that may be partly relevant to your daily life, say a shopping list, that you want to go to the grocery store, but mostly it's not directly relevant, as opposed to if we ask you about things that relate directly to your daily functioning. And so the point is that this may not be a better assessment for Alzheimer's disease, but it hopefully is a more clinically relevant assessment. So therefore, developing more sensitive, ecologically valid assessments, and we think the objective form, the performance-based assessments, will hopefully yield, these needed clinical outcomes that can measure changes in early Alzheimer's disease. And we're thinking, of implementing such assessments in prevention trials where we have older normal individuals who are at risk for Alzheimer's disease, such as the A4 study, also run by Lisa Sperling internationally. So here are some recommendations by Dan Marshall, who is a neuropsychologist at Birmingham, Alabama, who's done a lot of work on developing new daily functioning assessments, including the financial capacity instrument, which he developed. And so his recommendations are to assess cognitively complex functional abilities that are relevant to independent living. And you want to have a measure that has a lot of nuance to it in terms of the score, and include some time limitations. So sometimes it just takes longer to perform an activity, but you can still do it. And that could be the initial indicator that you have difficulties with daily functioning, as opposed to just not being able to do it, which is, or needing assistance, which is often the way it's asked with a questionnaire. And you want to have time limitations as well as the time to completion of the task, to see some of these subtle changes and how long it takes you to perform the task. So several years ago, we developed a new performance-based IADL instrument called the Harvard Automated Phone Task, or APT. And the idea was that individuals will perform assessments that include navigating what we call an interactive voice response, or phone tree, a phone menu. And so the first task was calling your pharmacy to refill a prescription. And so many pharmacies still do this, where you will dial in with your regular phone and enter information about a prescription refill that you need. And the next task was calling your health insurance company to select a new primary care physician. And again, many health insurance companies still have these phone menus that you have to navigate through, and can't easily talk to a live person or do this online. And so the idea here was that these are real-life assessments using a very widely available modality, a phone, a regular phone that has numbers and letters on it in case you need to enter information, for example, the name of this primary care physician. And so these will simulate activities that we do in regular life, and hopefully will be useful for tracking early functional changes. So this slide is just an idea of what the phone, the prescription refill task is like. And I'm just, hopefully you can hear this. I'll play the introduction here.
You have please confirm your date of birth by entering it in the following press 1 2-digit month, doctors followed by 2-digit day, followed by 4-digit year.
It looks like I messed up. I clicked both. So speaking of use of technology, I'm losing points here. Let me do it one more time.
You have reached a pharmacy. For prescription refills, press 1. Doctors, press 2.
Colleen, can you confirm that we heard that okay?
That was great.
Okay, good. All right. Yep. And so here's the other one.
Please confirm your date of birth by entering it in the following fashion. 2-digit month, followed by 2-digit day, followed by 4-digit year.
So this is just to give you an idea. This is what the phone menu sounds like. And basically, you go through different steps and then ask for a refill of your prescription. This is the more complex health insurance task, and here's the introduction for that.
You have reached a health insurance company. Please enter your member ID number followed by the # key. Only enter the number. If the number is preceded by letters, do not enter the letters.
And here's the sample of the main menu.
Please select one of the following options. To verify members on your policy, please press 1. To change your mailing address, please press 2. To order a member ID card, please press 3. For difficulties obtaining a referral approval by your primary care physician, please press 4.
And this goes on to 8 options. And so, so you have to listen carefully, and you can repeat if you didn't hear the option that you needed. And then you have to move on to selecting a new primary care physician. You have to enter the name of the physician. You have to enter the name of the city. And so, so it becomes pretty complex.
You have reached a health insurance company. Please select one of the following
member
options.
ID number
To
followed by
verify
the
members
pound
on your
I am
policy.
having
Please enter
technical
the number.
difficulties.
To change your mailing address by letters, please do not enter the letters. To order
Sorry,
a
1
member
moment.
ID card, please press 3. For difficulties obtaining a referral approval by your primary care physician, please press 4.
Sorry, I just realized that advancing the slide also plays the audio, so I apologize. Let's move on to the next slide. So the initial experience that we've had with the phone task, we piloted this on over 200 participants. A bunch of them were young, normal individuals, 45, to just make sure that mostly college kids can do these tasks. And then our main target was the older normal individuals, so CN, and so we had 141 of those. And then we also had 21 who had mild cognitive impairment, specifically with memory impairment. So everybody underwent standard cognitive tests as well. A very small subset, 19 individuals, had MRI scans as well. And the scores were based on total time for completion, number of errors, number of repeated steps, number of correct completion of the task. And the primary outcome measure was an adjusted time that was adjusted for correct completion of the task, so kind of accuracy. And so here, this busy table shows you the demographics for our participants, and you can see that the young normal individuals were mostly college age, the older normal individuals were in their mid-70s, and the people with mild cognitive impairment were a little bit older, in their late 70s. Aside from the mild cognitive impairment, we had a majority of female participants. And for the young normals and older normals, we had good representation of minorities, but not so much for the mild cognitive impairment group. Everybody was highly educated. Of course, since a lot of these young normals were still in college, they still didn't get their degree. So, but they were in college, so also I would say highly educated. We had a measure of intelligence, which was high as well. So this is not necessarily a representative sample, although at least for the normal individuals, it was more diverse in terms of race and ethnicity, but not necessarily in terms of education. So the cognitive performance for the normal individuals, young and old, was completely normal and very good. For the mild cognitive impairment folks, they had mild global cognitive difficulties and certainly impairment in their memory, which was a criteria for being in that criterion for being in that group. And so for some initial associations, so we looked at different demographics within the main group of interest, the older normal individuals. We looked at the two tests, the prescription refill and the health insurance task. And what you can see is that older individuals had a little bit more difficulties performing the test. With the complex test, the health insurance one, there was better performance, worse performance if you had lower education and lower intelligence score, and also a little bit worse performance if your global cognitive function was worse. And then for both tasks, you could see that the measures of processing speed and executive function or complex attention were strongly related to those assessments. And then looking at how people perform on these different tasks. So basically the first task, I'm going to focus on the old normal individuals, took about a minute to perform. There are few errors and almost everybody completed correctly, so 98.6%. The second task took about 3.5 minutes to perform. There were some errors and 88.7% completed correctly. And so most people were still able to complete it correctly, but not everybody did. And then you can see for the mild cognitive impairment, 65% completed correctly. So it was really challenging for that group. Here is a little graphic depiction of the difference between groups. So this is for the prescription refill, and you can see that there is a difference between all three groups. It's not a big difference between the young and old normals, or between the old normals and MCI, but it is there. You can see there's a much clearer difference between groups and the complex task, the primary care physician or health insurance task. And so that one really does seem to differentiate very well between the groups. We did a little reliability or test stability assessment. And basically what we see here is that after taking the test within a period of about 2 weeks, people perform about the same. And we have also an alternate version of this test that we compared to, and that was also, the performance was about the same in the older normals. So it was not quite as strong for the MCI, but it was still good. And then we looked more closely at the cognitive function relationship, adjusting for various things, so age, education, and race, and premorbid intelligence. And basically we saw strong associations with the measures of processing speed and executive function with these tasks. More so for the complex task with executive function, and more so for the simpler tasks with processing speed. And then we also looked at some other elements that we adjusted for. So hearing acuity, basically as part of the test, we asked individuals in the very beginning to punch in a series of numbers to make sure that they hear okay. And there was no problem there. We also measured how long it takes them to do that. And so we could account for the speed and hearing, and that did not affect these relationships. And then we also asked how difficult the test was, and that did not seem to affect the associations with cognitive function. So it seems like these daily functioning measures do match well with cognitive function in older normal individuals. Then we looked at some other assessments of daily functioning for comparison. So we looked at a questionnaire that is supposed to be more sensitive, focused on individuals at risk for Alzheimer's disease used in prevention trials. It's a modification of the ADCS-ADL. It's called the PI is the modification. And we had 38 participants, and it's administered to both participant and the study partner. And what we could see is that in people with mild cognitive impairment, that there was an association for the simpler task with the study partner report. So people who have cognitive impairment, their study partners seem to report more accurately and relate that to performance on our objective assessment. And then for the more complex tasks, the health insurance tasks, and the normal individuals, they self-reported difficulties that were related well to the performance on the more complex tasks. So interesting that for that assessment, you potentially needed both study partner and participant at different stages of cognitive function to report more accurately. Whereas for us, I mean, using the Harvard app, the phone menu, you could capture it by just assessing the participant directly, and you don't need separate assessments. We developed a sensitive questionnaire of our own that was based on 3 other questionnaires that were available, and we did a bunch of analyses to kind of pick the most sensitive assessments, questions within those. And then basically we used that questionnaire that we developed to relate it to the Harvard app. And what we saw was that for the more complex task, in this case, both participant and study partner report related to it. Next, we looked at another objective assessment that was developed by Sarah Kaya and David Lowenstein out of the University of Miami at the time. And this was a tablet-based assessment, abbreviated the CFAB. And we used 2 of their tasks. One is actually very similar to ours, a prescription refill. You do it on the tablet, and you get the audio through the tablet, and you refill the prescription. The next one was an ATM set of tasks, which is arguably probably the most ecologically valid assessment that we can do, because currently most ATMs are actually touchscreen interface, so they look like tablets essentially. And there are a few tasks that were needed to be done on the ATM, like transfer money, withdraw money, and so we decided to compare our assessment to the CFAT. And what we found is that there was an association across the different assessments, our prescription refill and no prescription refill, and the ATM task and our prescription refill, and also our complex health insurance task. So there were associations across all of these, which was good to see. Next, we looked at some longitudinal data. So we had repeated measures of our phone task, as well as repeated measures of cognitive assessments. And the bottom line is that we did see an association between worsening of performance on our phone task, as well as worsening performance on cognitive function, measuring global cognitive function, as well as processing speed and executive function and memory. And here are some graphs to give you an idea of that. And what we're focusing on here is global global cognition with the mini mental state exam, or MMSE. And there are four images here. If you look at the top left corner, what we're seeing here is people at baseline who had good memory, had poor memory function, and also at the end had poor memory function. And what you can see is over time, they perform worse on the prescription refill task. Whereas individuals who start off with good cognitive function and end with good cognitive function perform the same over time with the prescription refill. It doesn't get worse. And then there are these in between. And so this gives you an idea that it matches well with global cognition. Then this one here is focused on executive function, the TRAILS-B test, which you have to alternate between numbers and letters and connecting the dots there between them. And individuals who start off with a good performance, low score, doesn't take them long to complete the TRAILS-B or executive function task, and also doesn't change much over time. There you see that there's not much change in the complex phone task, the health insurance task over time. Whereas if you start poorly on the executive function test and you end poorly, you will also get worse on the on the health insurance task. And so this shows you that, again, there's a match between the performance of the daily functioning and cognitive function over time, which was reassuring to see that. Then you may recall I said we had a very small sample of individuals who underwent an MRI scan, 19, and within those 15 were cognitively normal. And what we saw within those individuals, was that there was a strong association between worse performance on the complex task and lower or less thickness or thinning of the brain, in particular in the inferior temporal region, which is an area in the brain that's affected early on in Alzheimer's disease. So basically suggesting that atrophy or volume loss in the brain is associated with worse performance on this complex task. This was a very strong association, but a very small sample. And so we wanted to replicate this later on, which we're working on now, and we'll talk about in a bit. So to summarize, our initial experience with the Harvard APT, which is a novel ecologically valid performance-based IADL test targeting early stages of Alzheimer's disease with complex tasks, which are real-life, practical, quick, and easy to administer, is encouraging. So just remember, these two tasks for the cognitively normal older individuals take less than 5 minutes to administer, can be done with a regular phone, can be done from home, or could be done in the research clinic. So very practical assessment that's quick. We demonstrated a nice difference across diagnostic groups. We also saw associations with different cognitive functions and other assessments of daily functioning, questionnaires that are sensitive, as well as other objective assessments like the tablet test. We also saw an association in a small group with atrophy or cortical thinning in the brain, even within the older normal individuals only. And these were independent of things that could be confounding, like hearing difficulties, motor speed, or how quickly you punch the numbers on the phone. And there was good stability of the test. And it also tracked well over time with cognitive function. So a lot of positive things for validating this instrument. And so this strongly suggests that this could be used, for screening and detecting the earliest changes in daily functioning in individuals at risk for Alzheimer's disease. And so we weren't satisfied with that. We developed a more challenging financial task. As you may recall, we mentioned that, in complex daily functioning, often we assess finances, and there's one particular assessment that's completely for finances, the financial capacity instrument. And so we thought this was an important aspect of daily functioning to test as well. So we developed a bank task. And in this task, you're supposed to transfer money from one account to another in order to be able to pay your income tax. Now, this particular task may not be as commonly used as the prescription refill or health insurance task with the phone, because often now banking is online and not as much by phone like this, and so may not be quite as ecologically valid. That said, of course, this is our medium is the phone, and so we did it with the phone. So here's a very complex image of the different steps, and I'm just going to play the intro for you.
You have reached the bank. Please enter your checking account number followed by the # key.
And then I'll play some of the main menu for you.
Please select one of the following options. To open a new account, please press 1. To pay a bill or make a payment, please press 2. To make a transfer, please press 3. To order checks, please press 4.
So I'm not going to go over everything that goes in this task, but there are a lot of steps to it, and this is more complex. And here's our initial experience with fewer participants, with 62 participants. Similar breakdown to what we had with the larger group in terms of having mostly the older normals represented here. The average time to complete this was about 5 minutes. It did differentiate between groups, again, young normal, older normal, and MCI. And it related significantly to the complex primary care physician or health insurance task. And in older normal individuals, it was associated with lower education, worse performance on this was associated with lower education. So again, kind of similar to the complex health insurance task. So basically, when comparing these three phone tasks, we kind of have incremental complexity. When we combine these, yields a pretty robust assessment of daily functioning, and we can avoid what we call floor effects or ceiling effects, where basically people score too well or too poorly if they're in a certain category. Our target here, the cognitively normal individual. So there's a wide range of performance that you can have on this, which is helpful in terms of having a test that will tell us how different people are doing even at that early stage. And so this leads me to a project that came of this. So we spent a few years developing this test, and then we asked the NIH for funding to be able to validate it further with more scans of the brain. And so currently we have two studies that are funded. One that I lead and one that Dr. Almarillo in our group leads. We've been recruiting participants, so 50 older normal individuals, 100 individuals with subjective cognitive decline where they perform normally on testing, but they have, they report concerns about their cognition that we can measure with questionnaires, but not on their testing. So a little bit at risk, more so at risk than older normal individuals, and then 50 individuals with mild cognitive impairment with mild memory impairment. And so these individuals undergo the Harvard app, the phone task. Some of them undergo the tablet task and the financial capacity instrument. And then all of them also undergo the questionnaires that are sensitive for daily functioning, the ADCS, ADLPI, and the CFI. And they undergo a standard cognitive battery every year for 3 years. They also undergo imaging. And so an amyloid PET scan, a tau PET scan, and an MRI looking at the structure and function in the brain, which is what we primarily needed the NIH funding for, because those image scans are expensive to run. What we've also done is added blood tests, looking in the blood for markers of amyloid and tau with the help of Dr. Selko from Brigham, who has developed these assessments in the blood. And so these two studies are ongoing, and we're still recruiting participants, but we hope that we can get information about how these tests relate to these sensitive biomarkers, imaging and blood. So in the next couple of minutes, I'm going to switch gears to a new assessment that we developed over the past couple of years using a smartphone, which we call ASSET, the assessment of smartphone everyday tasks. So ASSET is also meant to be a sensitive test of daily functioning, but this time using a different technology that's becoming certainly much more prevalent. So before we had a dumb phone, now we have a smartphone. And so the main test or task that we have in this particular assessment is using a simulated patient portal. And you have different things to do on the patient portal. So request a prescription refill, make a payment for an emergency department visit, schedule an urgent appointment with your primary care physician because you have flu-like symptoms, and schedule a weekly physical therapy appointment. And for the two appointments that you end up requesting, we also ask you to add them to a calendar, which is also on part of the test and is part of the interface that we created. We also have some pre-tasks that we added. One, a calculator task, basically to assess how quickly you can punch numbers on your smartphone, and if you can actually see them where they are, and on your smartphone, and if you have any issues with touch, tactile, and so kind of trying to compensate for those difficulties that some people may have. And we also have some tasks that assess your familiarity with the use of a phone. So we have questions about different task usage, frequency, and familiarity. And then we also have something that's a little bit more objective. We ask you to change the settings on your phone. Keep in mind that all this is within the app that we developed. So it may look real, but it's not actually. You're not changing anything on your phone or adding things to your calendar for real. It's within the app. It just looks like other apps that you would have on your phone. And then we also have a post task just asking about the difficulty of performance. And below are some images of what this looks like. So our initial experience, a much smaller group because this is a newer test, which we've been piloting at Brigham and more recently added to MGH to some of the studies that I mentioned before. So we had 10 young normals and 22 older normals who underwent ASSET and some other assessments of daily functioning and cognitive assessments. We plan on bringing in people with mild cognitive impairment soon, and we'll have people complete this remotely as well as part of the piloting. And so the older adults who completed all these assessments in about 7 minutes without assistance, and it was challenging, but it was doable. And recently, as I mentioned, we started adding ASSET to the imaging studies at MGH that I previously mentioned. And here's our initial experience. And so basically, these are demographics. Sorry, these are showing you the performance on the pre-tasks, and the young normals perform better on the pre-tasks than the old normals. in terms of the time that it took them. They took them less time, and they were more accurate. This rate measure here is accuracy, and so the young normals were more accurate than the old normals. This is for the phone settings. And then the patient portal, which is what we're most interested in. Again, the young normals performed faster and more accurately than the old normals, as we would expect. Interestingly, with the calendar task, it was about the same for how long it took and how accurately they performed, the young and old normals. And so we're not sure what that means. We'll obviously test this in many more individuals and get a better idea, hopefully. But at least the patient portal, which is our main set of tasks of interest, there was a clear difference. We actually recently received additional funding from the NIH to expand our efforts with ASSET. This funding was obtained by Dan Tatter, who is the CEO of ADK, the company that helped me develop ASSET, and of course myself. So this particular funding is a partnership between business and academics. The NIH has grants that are modeled for that type of interaction, in addition to the more standard grants like the ones mentioned earlier. And so there are two phases to this particular grant. That's a 3-year grant. The first year, we'll create alternate versions of ASSET, and then we'll pilot these versions at Brigham primarily, maybe some at MGH, with a small group of individuals, 60 participants across different diagnostic groups. And then we'll also test these at home remotely. And then the next phase is a larger validation of ASSET. It will be a 2-year phase. And so what we'll do here is have 5 centers across the country validate it. So at MGH, these are Alzheimer's disease centers. So MGH, UPenn, Indiana University, Madison, University of Wisconsin. And of course, now we're going to test my memory. The last one is eluding me, Johns Hopkins. And we'll be recruiting 500 participants who have their annual cognitive assessments and clinical assessments as part of these Alzheimer's disease centers. And we'll add to that annual assessment ASSET in person, as well as monthly remotely. And a lot of these individuals have scans of their brain or spinal fluid assessments, and so looking for amyloid, and so we'll be able to also relate ASSET to amyloid status within those individuals. So that grant was awarded a couple of weeks ago. so we're just starting to work on that. So we're very happy to have that opportunity as well. And I think with that, I will end. And I want to thank many people who helped with this work. So many colleagues, as you can see on the left, funding from primarily the NIH, as well as a philanthropic funding from the Vettel family, as well as the Poles family. Riproad is the company that developed with me the phone task, the Harvard APT, and then ADK, as I mentioned, developed ASSET. And of course, we can never do any of this work without our dedicated participants and study partners. So we really thank all of you because you are in the audience for helping us figure out if these tests are helpful and can be promising for the future. And so I think that is the end of my talk, and I'll just some of our team here, and I will end there. And I'm happy to take any questions.